A little bit of background, what they share in common is actually both of them were the Chair of Medicine Scholars awardees, which is a monetary award to help junior faculty as they transition into the physician scientist role and principal investigator role. And just a little bit of background on each. Dr. Chu, her undergraduate degrees are from Cornell as well as Oxford. And then she went to Duke for medical school, which included a Fulbright scholarship, and then did residency in the Harvard system at Beth Israel and infectious disease fellowship at the University of Washington. She joined the faculty here, and she's an assistant professor in the division, practices primarily at Harborview Medical Center. Her research is focused on maternal vaccines, in particular vaccines against influenza and respiratory syncytial virus, with both domestic and international work. And Dr. Seshadri, he had his undergraduate training at Rutgers, followed by medical school at New Jersey Medical School. He concluded a research year at the Howard Hughes Medical Institute at the NIH. He completed residency at Duke, and then infectious disease fellowship at Mass General, and then a senior fellowship year here at the University of Washington. He's now an assistant professor in the infectious disease division, as well as an affiliate investigator at the Fred Hutch. He attends at both UW and Harborview. His research focuses on the immune response to tuberculosis, including ongoing efforts to develop a tuberculosis vaccine. We're very pleased to have them both here today, and they're going to talk to us about developing effective vaccines to reduce the global burden of pneumonia. Please help me welcome our presenters today.
Thank you, Joe, for the kind introduction, and thank you for giving us the opportunity to speak to you today about our research interests. We are not going to the White House, so this is a perfect opportunity. So, first of all, my financial disclosures. I receive funding from the Gates Foundation, CDC, NIH, Thresher, and PATH, and my institution receives research for clinical studies from GSK and Pfizer. The topics we'll be covering today, so first of all, I'll go over the global disease burden due to pneumonia, and then focus specifically on vaccines that are currently in development for respiratory syncytial virus, RSV, and influenza. And Chetan will go on to talk about vaccine development for tuberculosis. So as most of you probably know, pneumonia is the leading cause of childhood mortality worldwide. It accounts for 18% of deaths in children under age 5. When we look at the specific etiologies of pneumonia in this population, people have done prospective studies looking at both viruses and bacteria. And of the viruses, RSV accounts for the substantial majority of etiologies of viral pneumonia. And in terms of bacterial, strep pneumo and H. flu are the primary pathogens. When you look at this list of the 4 pathogens, RSV, flu, strep pneumo, and H. flu, 3 of the 4 already have a vaccine that is safe and effective and is either in use or about to be rolled out in most resource-limited settings. The one really where there is no vaccine and where there's the greatest unmet need is RSV. And this is a quote from a recent paper in The Lancet where they said that the lack of an RSV vaccine is the major obstacle to the achievement of the Millennium Development Goal of decreasing under 5 mortality. So to an audience of internists who probably don't think about RSV on a regular basis, as I didn't before I started my research, RSV is a negative sense single-stranded RNA virus in the paramyxovirus family. It's the most important cause of bronchiolitis and pneumonia in children, and as my mentor, Jan England, tells me, it's the #1 reason why pediatric hospitals go on divert. Transmission is via direct or close contact with secretions, droplets, or fomites. And almost all children are infected at least once by age 3, if not 2 to 3 times. And then you go on to become repeatedly infected throughout your lifetime. But as you become an adult, you have less severe disease. And as a healthy adult, most of the time with RSV, you have a mild upper respiratory tract infection. Then when you become older or you develop chronic lung disease like COPD, asthma, RSV really causes the same burden of disease as flu in these populations. And Ann Falsey and Ed Walsh from the University of Rochester have done many large prospective studies showing that in non-pandemic, non-epidemic years, flu and RSV cause the same number of hospitalizations in the elderly in the United States. So this is a graph from the CDC showing the number of hospitalizations due to RSV by age. And you can see from here that the majority of hospitalizations due to RSV, and therefore the greatest burden of disease in the United States, is really in children under age 4 months. And so the thought of developing a vaccine is really to focus on this age group, which is a challenge, as most of you know, for vaccine development, because it's hard to immunize babies who are under 4 months of age. So in terms of the global burden of respiratory tract infection due to RSV, a recent study in The Lancet estimated that there were 34 million cases of RSV-associated acute lower respiratory tract infection in children under age 5 worldwide in 1 year. And to put this in perspective, this compares to 14 million cases of pneumococcal pneumonia, 8 million cases of H flu, and then about 10% of these, or 3 to 4 million, were severe enough to require hospitalization. There are 66,000 to 199,000 deaths, and then most importantly, 99% of these deaths occur in resource-limited settings. And the reason why they occur in resource-limited settings is because they don't have supportive care in those places, and because most of the risk factors for severe pneumonia, like malnutrition, household crowding, indoor air pollution from the burning of cow dung or vegetable matter for fuel, are all problems of the developing world and not really things that impact, that we think about here in the United States. So this is a study that we performed in Nepal over the past 4 years, where we enrolled 3,500 infants at birth, and we followed them until age 6 months with weekly household visits to ask about symptoms of respiratory illness. And every time they had an episode of respiratory illness, we collected a swab and tested it for 12 viruses by PCR. And what we found in this population was that 10% of infants in rural Nepal have a symptomatic RSV illness in the first 6 months of life, and that 70% of these had lower respiratory tract disease. And we found also that over the course of 3 years, in the yellow, you can see that there's a clear peak to RSV between the months of September and January every year, and that the major risk factor for acquiring RSV was birth before this time period. So the other risk factors that we found, not surprisingly in this population, were things like lack of maternal education, other children under age 5, household crowding, use of an open indoor cook stove, being born preterm, and then most importantly, the season of birth as the primary predictor of acquiring an RSV infection. And the graph on the right shows that RSV incidence by gestational age of birth. And this is important because we know that in the United States, preterm birth is the #1 risk factor for RSV disease, for severe RSV disease requiring hospitalization. But in resource-limited settings, we don't have very good ways to measure gestational age because most women do not access routine prenatal care. Most women do not get ultrasounds to date their pregnancies. So in our study, we enrolled women during pregnancy. We did a house-to-house census every 5 weeks of all women of childbearing age. And when they missed their menstrual period, we did a urine pregnancy test. So we were able to date their pregnancies fairly accurately. And we found that in rural southern Nepal, that birth between 20 and 31 weeks was associated with significantly higher risk for RSV disease as compared to babies who were born at 37 weeks or greater, full term, which is a finding that we have found in the United States. But also is a problem when you think about developing a vaccine, that you really have to develop a vaccine and then target it to this very high-risk population of preterm infants in resource-limited settings. So how do we prevent RSV currently? So there's no vaccine, there's no effective treatment. In transplant recipients in the United States, we give ribavirin. In the pediatric population, preterm infants or those with chronic lung or heart disease like those with VSDs, we recommend a monoclonal antibody prophylaxis, which is called palivizumab or Synagis. And that's an antibody that's directed against a surface protein called the F protein. This will be important later on when I talk about vaccines. For healthy term infants, who are by far the majority of the infants who get hospitalized with RSV, as well as older patients and transplant recipients, there is nothing that we can do for them. We recommend that they wash their hands, and we recommend mothers deliver their babies in June or July to avoid RSV season. So really what we need is an RSV vaccine. So why don't we have one? There are many obstacles to RSV vaccine development. The major one is that in the 1960s, there was a clinical trial of a formalin inactivated RSV vaccine in infants in the United States. And in this trial, receipt of the vaccine led to augmentation of disease when infants were subsequently exposed to RSV during the next season. And one of the infants in the vaccine arm died. And this really put a halt to RSV vaccine development for about 50 years. But in the last 10 years or so, there have been really several vaccines that have come down the pipeline, which I'll go into. There's also no perfect animal model for RSV. Cotton rats are the model that's used for most studies, and they have less severe and shorter disease course than humans. And they're also not a good model for maternal RSV vaccines because the antibody that they generate doesn't cross the placenta. We know that there's incomplete immunity to natural RSV infection, and that if a baby gets it the first year, they'll get it their second year and their third year, and then they'll get it into adulthood. And then finally, as I brought up earlier, the primary target population for an RSV vaccine is really the very young infant who's only 0 to 4 months of age. And they have an immature immune system, and they often have maternal antibody present, which can interfere with response to vaccination. So this is a snapshot from PATH showing the current vaccines that are now in development. And this has really expanded in the last 5 to 10 years. At the top, you see the live attenuated vaccines, and those are all in phase 1 trials, and those are intended for children who are older than 6 months of age. Not very many people are willing to go into the 0 to 6 month crowd because of the history of the formalin inactivated vaccine, and also because it's very hard to generate an immune response. The most promising ones are the particle-based and the subunit vaccines by GSK, MedImmune, and Novavax. And the Novavax one is now in phase 3 trials in the United States, or actually right now, phase 3 trials in South America, but about to go into the United States this fall. One of the major breakthroughs in RSV vaccine development happened about 5 years ago, where a group at the NIH was able to determine the structure of the RSVF protein. The RSVF protein is the surface protein. It's the target for palivizumab, and it's what mediates the attachment of the virus to the host cell membrane. And on the left is the prefusion form, so the F before it attaches to the membrane. And then what happens when it attaches is that it folds in and it forms a lollipop. And that's a very stable form. The group at the NIH, led by Barney Graham, was able to stabilize the prefusion form. And they found that the neutralizing activity of human sera is mostly from prefusion F antibody. And based on this, prefusion F can now serve as a candidate antigen for vaccine development. So most of the vaccines in the last 1 to 2 years that are in development are focused on prefusion F. If you're in the RSV vaccine world, people keep on talking about, is it a post-fusion F vaccine? Is it a pre-fusion F vaccine? The Novavax one is a post-fusion, but it's actually working quite well. But the other ones that are coming down the pipeline are pre-fusions. So the other concept to understand in terms of vaccination for both RSV and flu is the concept of maternal immunization. So very briefly, maternal antibody is generated in response to infection. It crosses the placenta, mostly in the 3rd trimester, and really peaks between 36 and 38 weeks gestation. So by the time a baby is born, they have often greater than 100% of the maternal antibody in their system. This decays quite rapidly. And then over time, the baby is able to generate their own antibody in response to infection. But there is this window of vulnerability between 0 to 4 months when maternal antibody is going down, but the infant is not able to generate their own antibody. And that's really when infants are most susceptible to severe disease. The concept with maternal immunization, which is already used for tetanus, for flu, and now also the ACIP recommends for pertussis, is to close that gap. So what you do is you vaccinate a mom and you boost their natural antibody level. The natural antibody level then takes a longer time to get below the protective threshold, and you effectively close that window so that so that the baby is then able to generate their own antibody in response to infection. So we found this to be the case in Bangladesh. So in Dhaka, we enrolled 149 mother-infant pairs. We collected serial blood samples from them, and we tested them for RSV neutralizing antibody. And what we found was that maternal RSV antibody was highly correlated with cord blood RSV antibody, so that if you give a mom a vaccine, that antibody will then transfer efficiently across the placenta. The antibody half-life was about a month, which has been shown in many other studies with many other pathogens. And that increased cord blood antibody decreases our infant's risk for RSV infection, and also increases the amount of RSV antibody in the infant above the protective threshold until they are able to start generating their own response to infection. So Novavax recently completed their phase 2 clinical trial in pregnant women, where they immunized healthy pregnant women at 35 weeks gestation with an RSVF nanoparticle vaccine. It was completed in January 2016, and they haven't published the results yet. But the initial results are very promising, and it's safe and immunogenic, and they're starting phase 3 trials, or they have already started their phase 3 trials, and will be in the United States this fall. The problem, as I would point out, though, with the Novavax strategy and with many other maternal vaccine strategies, is they're really focusing on giving this to women at between 30 and 35 weeks. If you think about the babies who are at highest risk for RSV infections, the ones who are born at 28 to 31 weeks. So vaccines are really the only way to go in resource-limited settings. And you will still miss that population if you're giving your vaccine so late in the pregnancy that you won't have any antibody that's delivered to these high-risk preterm babies. So the other option potentially for this group is a long-acting monoclonal antibody. So palivizumab is the one that you give to preterm high-risk babies to protect them from severe RSV disease. You have to give that every month. It costs thousands of dollars, and it's by subcutaneous injection. MEDI889 is a new compound developed by MedImmune, which is an extended half-life antibody, which is meant to protect infants throughout the entire RSV season with one dose. In a phase 1 randomized trial of 136 healthy adults, they found the half-life of the antibody to be 69 to 77 days, which is great. The safety profile is favorable, but we're still awaiting their phase 2 data. So moving on to flu. So a very brief review. Flu is an RNA virus, 8 separate segments. The segmented genome facilitates reassortment, so you have drift, which leads to the annual epidemics, and shift, which leads to the pandemics. And this antigenic variability leads to the need for a new vaccine every year. At the top is the flu that circulates in the northern hemisphere, and the bottom is the flu that circulates in the southern hemisphere. And you'll see that flu varies both by type that's circulating and also by time of year, so that, so if you are a tropical country like Singapore or Indonesia, or in our case, Nepal, trying to pick which vaccine to give when is challenging because the vaccines are available at different times, different strains are circulating at different times. It's hard to know what to give. So how do we prevent flu? So there's a safe and effective vaccine. The efficacy is 70 to 90% when there's a good match. And we know trivalent inactivated vaccines has been safe and immunogenic, and that's been well established over many years. The live attenuated vaccine also has a good safety profile. It may be better in children. And then it produces heterotypic immunity, which is an advantage when there's a poor match of the vaccine to the epidemic strain. And now we have a quadrivalent live attenuated, which covers H3N2, H1N1, B Yamagata, and B Victoria. So the WHO has, as of April 2012, prioritized pregnant women as the group as the highest risk group for severe outcomes and the number one group to receive the flu vaccine. And the reason for this is because we know that pregnant women are at high risk for severe disease. So as from H1N1, particularly in the third trimester, women who are pregnant are at more risk for hospitalization and for adverse birth outcomes. Seasonal flu vaccine is known to be safe during pregnancy, and we know that flu vaccine is effective in preventing flu in babies and in their young infants through maternal antibody transfer and possibly through cocooning as well, up to 6 months of age. So there's also a thought that flu vaccine in pregnancy may decrease risk for adverse birth outcomes. And that's something we really think about in resource-limited settings where there's such high rates of preterm and low birth weight babies. So we define adverse birth outcomes as preterm birth, which is less than 36 weeks completed gestation, low birth weight, less than 2,500 grams, and small for gestational age, which varies based on which criteria you use. So in a study in Bangladesh that was published in the New England Journal in 2008, Mark Steinhoff and his group found a 70% decrease in small for gestational infants in the flu vaccine arm in post hoc analysis. Observational studies in North America have shown that maternal trivalent influenza vaccine is associated with decreased risk of preterm birth and small for gestational age infants as well. But there have been no randomized clinical trials to look at this specifically. So the Gates Foundation decided to fund 3 trials to evaluate this. One in Bamako, Mali, one in Johannesburg, South Africa, and then the last one in the Sarlahi district, Nepal, which is the one for which I'm a co-investigator. So in comparison of these 3 trials, so they all have the same endpoint, which is safety and efficacy of the vaccine in mothers and infants. They were all from about 2010 to 2013, and sample sizes range from about 2,000 to 5,000 in Mali. The main differences between the 3 trials is that in our Nepal trial, we compared trivalent inactivated vaccine during pregnancy to placebo. In Mali, they compared it to meningococcal vaccine. In South Africa, they compared it to placebo, but they had 2 arms, HIV positive and HIV negative. In terms of geography, our site was rural, and the Bamako and the Johannesburg sites were urban. And then the HIV was markedly different between the 3 populations. The flu seasonality was also different in the three populations. In Nepal, flu circulated year-round. In Mali, it was a tropical site. We didn't know how much flu circulated and when. And in South Africa, we knew that it was seasonal, like in the United States. So the group in South Africa published their results now 2 years ago in the New England Journal. And what they found was that there was a statistically significant reduction in laboratory-confirmed influenza in HIV-negative mothers and infants with flu vaccine given during pregnancy. They also found that in HIV-positive mothers that flu vaccine was efficacious, but that didn't hold for the infant, suggesting that in HIV, transplacental antibody transfer is not efficient, which we also know for other diseases. And overall, their vaccine efficacy ranged from about 49% to 58% in their study. We haven't published the results from our study yet, but these are the preliminary results. So in Nepal, what we found was that overall vaccine efficacy in mothers was 31%. I would point out that we divided our study into two cohorts. Cohort 1, where the vaccine efficacy was 45%, and Cohort 2, where the vaccine efficacy was negative 2%. And I'll show why that is on the next slide. And for infant vaccine efficacy, the overall efficacy was 30%. And the reason why we think that there was such poor vaccine efficacy in the second year, or the second cohort of the study, is because of this. So this is a graph that shows the flu subtypes that were circulating in the Sarlahi when we were doing our study. So the yellow, the red, and the green are all A's, and the purple and the blue are B's, and the orange is B non-type. So B purple is Victoria, B blue is Yamagata. And you can see that there's a large peak of Yamagata B that was circulating in 2012. Which is about the time when we vaccinated our second cohort of mothers. And the vaccine that we were using was a trivalent vaccine that did not contain the Yamagata component. And to highlight this point, this is the immunogenicity data. And I only showed one of them, but it's similar for all of them, showing that the placebo is in blue and the vaccine is in the red. And you can see that there was a brisk response to vaccination with a rise in geometric mean titer for the hemagglutinin antigen for the mothers who were vaccinated, both in the postpartum mother's blood and then with an efficient transfer to the cord blood. So that it wasn't that mothers weren't able to mount a response to vaccination or transmit this antibody to their infants, but rather that the flu that was circulating at the time was just not covered by the vaccine. So the birth outcomes that we observed in Nepal. So we found a 15% reduction in low birth weight with flu vaccination. We did not find a significant effect on preterm birth or SGA, but the overall difference in birth weight was only 43 grams, which was less than what we had expected. We haven't published the data yet, but it's being prepared for submission right now. So in conclusion, pneumonia is the leading cause of childhood mortality worldwide. RSV and flu cause a significant burden of disease, with 99% of the deaths in resource-limited settings for both flu and influenza. Maternal vaccination has the potential to protect mothers and infants from severe disease. Maternal RSV vaccines are now in phase 3 clinical trials internationally. The WHO currently recommends pregnant women as the #1 priority group for flu vaccination. And now we have randomized clinical trials that show efficacy and protection of pregnant women and their young infants from flu through maternal vaccination. So I'd like to acknowledge a lot of people, including, most importantly, Jan England and Jane Kuipers, who are my mentors here, and our collaborators at Johns Hopkins University and in Nepal, and then the field staff in Nepal who did all the work to perform the trials. So thank you.
Thank you. We'll just take questions as a group at the end, if that's okay. Great. Well, I'd like to also thank Joe and the department for giving us this honor. I will thank Jay Shindur when he gets back from the White House. And I'll ask him to show me a selfie with President Obama. I also have no conflict of interest to declare. My funding primarily comes from the NIH, as well as the Gates Foundation, from the Ferland Foundation, and actually significant support from the Department of Medicine, the Chair of Medicine Award, as was described, and a Royalty Research Fund grant. I'm going to switch gears a little bit now and talk about tuberculosis. In thinking about the global burden of pneumonia, it's interesting that tuberculosis never really gets lumped under pneumonia, even though the main manifestation of this disease is a pneumonia. And it gets its own line item, I think, because it's such a huge problem, and it's a single agent, and it always has been. WHO statistics that were recently released a couple months ago show that we've made tremendous progress. 43 million lives saved in the last 15 years, a near 50% reduction in mortality. During that time, however, we've made such incredible gains in reducing HIV-associated mortality that for the first time in many years, TB has now retaken the #1 spot as the leading infectious cause of death. So it's more than HIV. Impressively, in this report, even among people living with HIV, more people die of TB than HIV now. So we've made tremendous gains in HIV. We have a ways to go with TB still. And keep in mind, this data is all talking about active TB. It does not get at the vast, vast reservoir of people with latent TB, which is kind of the elephant in the room. And some interesting modeling data from Chris Dye at the London School kind of get at this point. So just focus on the bottom graph. That top blue line is the optimistic assessment of our gains in reducing TB-associated mortality, approximately 5% a year. And if we just keep doing what we already are doing, but just do it better, we can get to 12% per year and reach essentially elimination phase for TB in about 15 years. And this is one of the sustainability development goals from the UN. And that would be great if this was smallpox or polio, but it ignores the fact that we've got this huge reservoir in the background. So that's the top graph. So the top graph says, doing what we're doing, we get about 2% reduction in the number of cases per year. And we're never going to get to elimination phase. Well, we need nothing short of a revolution to get to elimination phase and get reductions of 20% per year. Keep in mind, this has never been achieved historically. No industrialized nation that conquered TB conquered it by getting reductions of 20% per year. So this is unprecedented. And it probably cannot happen without an incredibly effective vaccine. You think about what we've achieved with smallpox and now almost with polio. So what about TB vaccines? Well, the discussion of TB vaccines starts with BCG. And BCG stands for Bacillus Calmette Guerin, named after a French physician and veterinarian who developed this in the early part of the 20th century. And the history of BCG is inextricably tied to smallpox, interestingly enough. So BCG is an attenuated strain of Mycobacterium bovis, which is the etiologic agent for cows. And that's not an accident, because Jenner showed that you could use cowpox to vaccinate people against smallpox. They thought that this would be a good route to go. The other fundamental connection with vaccines is that this vaccine was developed at the Institut Pasteur, where Louis Pasteur pioneered the method of serial passage to attenuate an agent. So the classic example of this was rabies vaccine. And in fact, that's what Calmette and Guerin did. Over a period of 19 years, they serially passaged M. bovis in vitro until it lost enough of its virulence, but still maintained its immunogenicity, proved that it was effective in cattle, and very soon after that, in infant trials, was shown to prevent tuberculosis. So since approximately 1921, BCG has been the standard of care for TB vaccination worldwide. It is still used by virtually every country in the world. There are a handful of countries like the UK and Australia that used to use it but don't, now that TB isn't a big problem for them. And there's only 2 countries that have never used BCG, the US and the Netherlands. Otherwise, nearly every country in the world still uses BCG. BCG works. 70 years of clinical trials through the bulk of the 20th century, summarized on the right graph, show that BCG is effective in preventing disseminated TB in infants. This is why it's still used. Infants do not transmit TB. Adults with cavitary pulmonary disease transmit TB. And there, the efficacy of BCG is much less. So the quoted statistics are anywhere between 0 and 80%. And again, this is 80 years of clinical trials through most of the 20th century. The last ones being performed in the 60s and 70s. And so we've known for about 50 years now that BCG will never get us to elimination phase. It's not going to stop the epidemic because it doesn't prevent transmission. And so we need a new TB vaccine, and we've known it for 50 years. So how do you make a new TB vaccine? This is a nice diagram from a review paper that's now about 10 years old. And the strategies really kind of fall into three main groups. And the outside red circle is a live attenuated vaccine, essentially BCG, some version of BCG, which gives you all the aspects of immunity that you might want to have. On the left side with the blue arc is an inactivated vaccine. Think of this like pertussis, which would be really good at generating antibodies. And on the right side in the green is a recombinant vector whose focus is to generate T-cell immunity. By and large, the field has really flocked to this third strategy, a focus on recombinant vectors and the generation of T-cell immunity. So it's worth explaining why. There's actually a pretty good case to be made for focusing on T cells. M. tuberculosis is an intracellular pathogen. It's not really obvious that antibodies would have a major role in preventing TB. And what you really want is good T cell immunity. There's a wealth of animal data to show that CD4 and CD8 T cells are essential for protection against tuberculosis. And I would say at some level, most convincingly, HIV has taught us this lesson. So CD4 T cell depletion due to HIV markedly increases your risk of developing rather tuberculosis. So an HIV-infected person with latent TB has approximately a 10% annual risk of developing disease, and an HIV-infected person has nearly a 10%, a lifetime risk rather, an HIV-infected person has a nearly 10% annual risk. So this is really sort of the background for focus on T-cell immunity. Here's a quick snapshot of the TB vaccine pipeline. This is a couple years old. I don't want you to get bogged down in the letters, just sort of pointing out the major categories of vaccines to drive home this point. You know, the green on the left and the light blue and the dark blue are either whole live vaccines or inactivated vaccines. And then all the black and yellow are the recombinant proteins, either constituted with adjuvants or with recombinant vectors. BCG works, so if you're going to trial a new vaccine, you can't not give BCG. That would be completely unethical. So the clinical trial strategies that have evolved are to boost the response to BCG by including a protein or a set of proteins that are shared between BCG and TB. Give that sometime in early childhood or adolescence, and then cross your fingers and hope for a good outcome. So this strategy got its day in court a couple of years ago. The main candidate that made its way all the way to efficacy testing was something called MVA-85A. This trial was performed by our major collaborators at the South African TB Vaccine Initiative and at the Jenner Institute at Oxford. And what they did was they included a recombinant antigen called 85A, which is shared between TB and BCG. They packaged it in a vaccinia vector, and they gave it to babies within 6 months of birth after they had received BCG, randomized to placebo or not, and followed them for 3 years. The primary endpoint was development of TB disease, and the secondary endpoint was development of TB infection as measured by a quantiferon test. The primary efficacy endpoint was 17% with a confidence interval of -30 to +40, and the secondary endpoint was -7% confidence interval of -56 to 27. So clearly didn't work. Not only didn't work, it was so definitely negative, it was hard to even put a positive spin on this. And the BBC and other news outlets really sort of took this home when the results were released. So where to? I have to say that this result was a real slap in the face, I think, to everybody in the field, and has forced a broad rethink about our strategy. I wish we had good news like what Helen reported about 5 years ago for RSV and a breakthrough, but we don't. We're actually at a point now where we're completely rethinking this whole strategy. And we need innovative approaches. So if you look at vaccines that work, for the most part, these are stable antigens over time, as shown on the x-axis, and they're meant to generate neutralizing antibodies, as shown on the y-axis. The diseases where we don't have good vaccines and we're trying really hard to generate T-cell immunity because we think they're important are HIV, malaria, and TB. And you heard some exciting data about malaria here from Bob Cedar just a couple of months ago. And so we don't have a precedent. We don't have a blueprint for how to make this work. Clearly, what we've been doing so far hasn't worked. So if we've agreed that T cells are important and this recombinant strategy of using a protein vaccine didn't work, maybe what we need to do is rethink the question of what T cells. And this is where this field sort of intersects with my general research interests. Now, the dogma in immunology is that T cells recognize bacterial proteins when they're presented by major histocompatibility complex molecules, class 1 and class 2. That's how antigen 85A worked in the vaccine. But we've known for a long time that T cells are much smarter than this. They recognize a much broader classes of antigens from pathogens, including mycobacteria. So in the middle diagram, what you see are T cells that recognize mycobacterial lipids that bind CD1 molecules. And on the right, believe it or not, T cells can recognize bacterial metabolites, precursors of vitamin B that bind this molecule called MR1. MR1 and CD1 are highly homologous to MHC class 1, but we know much less about how this system works and what its importance is to human disease. Part of that problem is the lack of good animal models. So again, my area is CD1 primarily, and humans have a very elaborate, evolved set of genes to process and present lipid antigens from different bacteria to T cells. And for whatever reason, in mice, this whole locus was deleted somewhere. And so mice turn out to be a particularly poor model to study this particular system. Major questions that still are in this field are whether lipid-specific T cells are important for protective immunity to TB. Are they capable of immunologic memory in the way that peptide-specific T cells are? And if so, then can they be modulated by infection or vaccination? If you think about it, the whole MTB bacteria or a live BCG bacteria has proteins and lipids. It generates vitamin B metabolites. It should have the capacity to stimulate all these different kinds of T cells. Yet we've made a conscious decision to focus on particular proteins, put them in viral vectors, and only activate those T cells. That didn't work. Maybe we need to sort of step back and think about this broader system. So to summarize some of our published data and then tell you a little bit about work that we're currently doing, a few years ago, we identified donors whose antigen-presenting cells lacked the expression of the CD1A molecule, and therefore were unable to stimulate T cells that were specific for a mycobacterial lipid presented by CD1A. Otherwise, these antigen-presenting cells were fully competent, and they could actually activate peptide-specific cells and do everything else they needed to do. We mapped this phenotype to a single nucleotide polymorphism in the promoter of CD1A, and in a genetic association study, what we showed is that that polymorphism is overrepresented in cases of tuberculosis in Vietnam compared to controls. So I can't claim a causal connection, but using a fairly novel human genetics approach, what we're trying to do is make the case that this system might actually be important for protective immunity. But we can't actually ascribe causality in this study design, and other studies, including animal models, will have to be done. But as I pointed out, the animal model for this molecule is lacking. We've also helped to develop new tools that enable the study of lipid-specific T cells. So until recently, this wasn't even possible. But a number of groups, including ours, have made contributions in this way. So we now have a panel of purified or synthetic validated lipid antigens from mycobacteria that we can use to start to ask these questions. We have functional assays that we can interrogate different kinds of T cells with these antigens. There are now tetramers available that you can load with particular antigens and actually stain T cells. And these methods can be combined with existing platforms of multi-parameter flow cytometry. We've helped develop new ways of looking at flow cytometry data. and analyzing it. And then finally, but not trivially, is the access to valuable clinical cohorts, for example, through the South African TB Vaccine Initiative, whether these are epidemiologic studies or actually samples from clinical trials. And I'll tell you a little bit about that work now. So in a study that we published last year, we asked a very simple question, which is, does studying T cells that are specific for lipids actually teach you anything that you wouldn't know if you were studying T cells that recognize protein antigens? And we took 40 South African adults, rather adolescents, from the Cape Town group, and we profiled a panel of immunodominant protein antigens, including antigen 85A, and a panel of lipids. And we simply just looked to see what the correlation was, and there was literally no correlation. So again, emphasizing the point that this system exists independently of MHC class 1 and class 2 to do something that is complementary and non-redundant. It's not doing the same thing. You are probably actually getting more breadth and more bang to have a whole bacteria that has the capacity to stimulate all these other kinds of T cells that we don't think about. More recently, this is unpublished work, we've used CD1-loaded, lipid-loaded CD1 tetramers to quantify the cells that are present in infected individuals. And what we see is between subjects that don't have TB, have latent TB, and have active TB, we clearly see an expansion of these cells in the setting of disease. Again, this is a pretty simple point, but it's the first time this has been shown because we finally have the tools to ask this question. So if it can be modulated in the setting of disease, potentially can be modulated in the setting of infection. And in this study, we used a whole panel of antibodies to assess the memory phenotype of these cells that stain with tetramer, and using computational methods to reduce dimensions and plot them in this particular way down on the bottom left. We find populations of naive T cells and memory T cells exactly analogous to what you would expect for traditional or conventional peptide-specific T cells. So this, I would argue that we're starting to generate the evidence base that this system can be modulated in the same way. It's not impervious to that. So to the question of whether lipid-specific T cells are induced by vaccination, I wish I had data to show you, but these studies are actually ongoing right now in collaboration with both SATV in Cape Town and Helen McShane at the University of Oxford. So, for example, here is a trial that was done and it was published, and the trial was designed to answer the question of whether BCG revaccination is safe in South African adults that have latent tuberculosis. And so 82 adults were HIV uninfected, positive skin tests, were randomized to receive BCG either before or after treatment with INH. And here is one arm of that study. Blood was drawn either before or after INH treatment and before or after BCG vaccination at various time points. And this study is completed. The blood has been drawn and frozen. And now that we have the tools, we can actually access these archive specimens and ask these questions. In the short term after BCG, do you see a change in lipid-specific T cell responses? What are their phenotypes? And up to a year after vaccination, is that change maintained? Have you made a demonstrable difference in the immunity of this person to a lipid antigen that then might actually correlate with the clinical outcome? So these studies are literally ongoing right now in the group. So to summarize, wow, I finished pretty quickly, but we'll have more time for questions. TB elimination will require a revolution in preventing new cases. There's no question about that. And a highly effective vaccine is going to have to be critical to that. BCG is not going to be that vaccine, and we've known it for 50 years. Boosting T cell immunity, I would argue, is still going to be an important part of the strategy, even if the failure of MVA-85A 3 years ago has forced us to rethink how we're doing this. And really, the whole field, I think, is more open to this idea of unconventional T cells. They are understudied, and they may hold the key to a better TB vaccine. So I want to acknowledge a number of people, Crystal Kwan in my lab, who did a lot of the flow cytometry, my mentor Tom Hahn here at the U, and Branch Moody at Brigham and Women's Hospital, and all our collaborators, including some whose work I didn't have a chance to discuss today. Thanks.